Hello, everyone. My name is Paul Weber. I'm afraid that we're having some technical difficulties connecting with Zimbabwe to get Professor Mugamiri, who is going to host this teleclass today. So that honor falls to me, but hopefully he'll be with us for the concluding comments because I think his discussion will be very interesting. Now, I'm delighted to introduce for the second time this month, Professor Francois Venter. Professor Venter is the executive director of Ezinsha at the University of Witwatersrand in South Africa. He has an MD and a PhD, not showing off at all. He has an active interest in public sector access to HIV and chronic care services. His work involves health systems research that directly translates into national programs. And if you joined his first teleclass 2 weeks ago, you will have noted his passion for his work and his take no prisoners approach. One publication referred to him as Professor Screw It, Let's Do It. Today, the topic is HIV in 2026, all you need to know. Francois, the floor is yours.
Thank you so much, and thank you again for the invitation. I'm going to try and be a little bit less ranty this time than a couple of weeks ago when I spoke about the pepper cuts and how it's affecting HIV programs, although I'll touch on it towards the end of the presentation. This is really to just give you a kind of a top-level view about HIV, where it came from, and how to think about it in terms of treatment and prevention, and really to give you a whole lot of sound bites about the epidemic. And I'm from South Africa, so I'm going to necessarily focus on South Africa, but South Africa is one of the countries the hardest hit by the epidemic, and I hope that by touching on it, I can give you some sort of insights into how to perhaps think about it, and certainly give you an idea of how what I've dealt with over the last 25, 30 years. There is an article, I was part of the writing group, published in The Lancet at the end of 2024, which is pretty up to date and freely available. And if you just Google The Lancet and my name, it'll pop up. It's a great review, not because I only did the treatment bit, but the other authors are sort of front and center of their field, and you'll get it's got a really nice high-level view, and it's referencing all the recent breakthroughs. So if you really want a bit of a view, that's there. These are my various disclosures, and one of the things about HIV is that we all grew up with, and there's obviously a variety of age groups listening to me at the moment, but for many of us, we grew up with a couple of epidemics of the last year. We all grew up, sadly, with COVID, which came and sadly hasn't completely went. But HIV, many of us grew up with HIV. When I was a teenager, I remember Princess Di sort of shaking hands with people with HIV, and kind of the first cases of HIV appeared when I was 10 years old. So it's kind of crept into my consciousness, since I was a kid. And the interesting thing is that the epidemiology of HIV has been plotted back by sort of viral historians, and they've tracked it back to villages in and around they've actually they've got these rivers that HIV-1 certainly, they've managed to track it back, looking at various repositories of the virus that have been found in fridges in various places. And these viral epidemiologists have managed to go backwards and do all these amazing basic science questions and things. And for those of you interested, there's amazing books that have been written about this by these people who've tracked, actually fairly certain that the virus actually jumped between species from chimpanzees into humans at these spaces here, and actually very slowly made its way in and around Kinshasa, and from the Congo, from Cameroon and around Kinshasa in what is now the Democratic Republic of Congo, and made its way across quite slowly across Central Africa, and pretty much through iatrogenic spread, interestingly enough, and followed the building of the railways through Central Africa, from the sort of the 1890s. And during this period of time, between the 1890s and the 1950s, spread very, very slowly through through Central Africa. And during the 1950s to 1980s, as air flights and travel just became more sort of more prevalent, started to enter into sort of Northern Africa, and then, interestingly enough, into Europe. There were quite a few unsuccessful seeding of the virus into Europe, and there's actually quite well characterized, say, for instance, in Norway, of families being infected in these countries, and then made its way across into the Americas. And again, it's not a terribly infectious virus in its chronic phase, so it didn't actually penetrate and take hold in these countries as much as people would think. It also started then to spread into Southern Africa during the 70s and 80s, and here it had a very distinctive difference, where it actually spread sexually through heterosexual spread, and took a very different dynamic during the 1980s, and spread very, very rapidly in Southern Africa, not sub-Saharan Africa. Again, very different dynamic to the epidemic that took place through the rest. And honestly, it's quite difficult for people to quite understand how quickly it spread in the Southern Africa, and how devastating it was in those countries. You can see the sort of drop in life expectancy, the slightly old graph, but you can see the drop in life expectancy in these key countries. In places like Botswana, the life expectancy actually dropped below 30 briefly because of HIV, and actually galvanized the government in Botswana, which is a very far-sighted government, to start taking forward its antiretroviral program. And you can see the impact of the antiretroviral programs in those countries as they start to implement it in the early 2000s, and how it managed to reverse much of that mortality. Never quite got back to normal, but managed to take hold there. So the first cases certainly were seen in the east and the west coast of the US, and actually were reported as two separate cases amongst gay men and hemophiliacs. And what was peculiar at the time is that they were actually two completely different things. So they were reported as this cancer called Kaposi sarcoma. And any of you who've seen the movie Philadelphia starring Tom Hanks will be very familiar with those purple lesions, that this kind of cancer, which previously was only really described as this rare cancer amongst Italian men, and actually had been described in Central Africa as well, this very distinctive form of skin cancer, and was suddenly seen on one coast of America, and then on the other coast as a form of fungal disease of the lung, a lung infection called PJP. Again, very distinctive, when people present very, very breathless. And the only reason people put them together was the fact that the blood tests of the particular form of the hematology at that stage looked very, very similar. And the patients tended to have thrush in their mouths, and they tended to have lymphadenopathy. And the clinicians in the US started putting two and two together in the space of just a month or two, and started putting this down, saying a lot of these patients were gay, and they were gay men, and they were hemophiliacs, and started to actually publish this in 1980. And you must understand, there was no way people thought this was a virus. And initially they thought maybe it was a mutant form of cytomegalovirus. A lot of these, particularly the gay men, were using drugs called poppers. A lot of people thought it was a CIA conspiracy, and a lot of people would be saying this sounds like COVID all over again. And there's something to be said about that. And there's a lot of fear at the time. You can understand why. And the virus was then only isolated in 1982. But as I said, when people went back and started retrieving, samples that were stored including in Africa, in laboratories that had been frozen often for decades going back, they actually realized that this virus had been circulating in communities going back into the 50s. They found pathological samples in the US, including in teenagers who'd been presenting with strange forms of cancer, and they'd go back and then test it for isolating the virus, and actually demonstrate that there were HIV actually had been spreading around America and Europe during the 50s. So this virus actually had been prevalent. It just was pretty rare in these communities. So what we know now is that Cameroon was the origin of the consensus now is that the virus HIV-1 at any rate, there's another form of HIV called HIV-2, pretty much seems to have been a form of xenotransplantation from these chimpanzees into humans, started to spread across the world, largely air travel, through the rest of the world. Within Africa, it seems to have been far more around the railways and a more conventional land travel. That original Central Africa thing was the iatrogenic spread, a fascinating story around reuse of dirty needles. And in Southern Africa, the spread was largely heterosexual. And why these differences occurred is still one of the big mysteries of modern medicine. HIV-2, which actually was a different ape, the green monkey, is actually steadily becoming extinct. It's less transmissible. It responds to different drugs, different forms of the antiretrovirals, but is steadily becoming extinct. I've never seen a case. There's only been 5 cases in South Africa. It's a concern in certain parts of Africa, but there are fewer and fewer cases that are existing all the time. So in South Africa, the first cases actually were described in Pretoria, but there actually was probably a case in 1980. There was a case study of a patient who presented with Kaposi sarcoma of the skin and a TB nodule in the same cancer, which the man had lymph nodes and thrush, and he probably was the first case in South Africa described in Cape Town, in fact, and then disappeared from the hospital. So the virus hadn't even been described at that stage. So he probably in 1980 was our first case. And as I said, then we started seeing gay men associated with the local airline starting to present with PTSD, and the rest was history. What was interesting in South Africa, because we were in the midst of apartheid at that stage, was a whole lot of donated blood that was brought into the country, and we started to see it amongst our own hemophiliacs. And interestingly, the South African epidemic looked very, very similar to the US epidemic. It only started to change in 1990, as apartheid started to end. Our borders started to become more porous, and our epidemic started to look much more similar to the rest of Southern Africa. And then we saw this explosive growth amongst the heterosexual population, which initially changed by province and then became far more heterogeneous as the 90s continued. So for those of you, this is going to start making sense, that you, depending on where you were in the world, but certainly in the West, the 80s were just the whole world. It was just fear and stigma in the 80s. You know, in sort of the northern hemisphere of Europe and certainly North America, it was very much about men who have sex with men. It was very much concentrated on hemophiliacs, injecting drug users, and it was a big epidemic. You must understand that it was the commonest cause of death amongst men in big cities in America, for instance, in the US. While if you go further into sort of the East, into Asia, it was still a disease amongst MSM, men who have sex with men, but also so there you start seeing a very large epidemic amongst sex workers and amongst transgender populations. While in Africa, particularly amongst Southern Africa, it was explosive, as I said, a heterosexual epidemic. And it varied quite dramatically across the continent, while in very far Northern Africa, it was still a disease amongst gay men. And in those days, really, there was almost no treatment available. It was essentially palliative care, where we would treat opportunistic infections like TB and PJP and things as best we could. In the very late 80s, the first antiretrovirals were coming forward, but they were very toxic and usually would buy you a month or 2 of life. And really, the disease was dreadful. I mean, really was the period very much symbolized by the death of Freddie Mercury, where he had access to the best doctors in the world, but was wasting away in front of everybody's eyes, but died a few brought forward his AIDS diagnosis just before he died. The 90s, though, was when things started to change. It's when we started to combine antiretrovirals together, modern therapeutic options started to come forward. And almost within a year, I had a friend working in Canada, actually, in the hospice movement, who was looking after hospices full of people with HIV. And he said, like, the hospice closed almost within a year. He just said the drugs were so potent that as soon as they started rolling them out, people just went home. There were a lot of side effects associated with the drugs, but they were still so potent that they worked so well. And at the same time, the recognition of this massive wave of mortality across Africa, it was certainly there in the late 80s, but I think the sort of scale of the disaster, particularly in places like Uganda, was starting to be noted. And then the 2000s started to occur, and I think this is when the advocacy movement, and this is when I started becoming involved in HIV, started to become apparent, and certainly the hypocrisy of South Africa started to become apparent when our president, who refused to even acknowledge HIV existed. I was working in the hospitals, and literally there were just no beds available. We'd have people on the floor. There were just so many people dying in the hospital I was working in, and this denialism of HIV. And for the first time, suddenly the advocacy was starting to bear fruit, where drugs were starting to become available in Southern African countries, and certainly my country. There was suddenly this push against the president, and he was eventually pushed out of power, and we got drugs in, and we had this massive scale up of access to antiretrovirals. And then the drugs got steadily less toxic, and we started to roll them out, and I'll talk about them in just a moment. And now South Africa has the largest treatment program in the world. We had drugs across the continent, largely facilitated by PEPFAR, I talked about 2 weeks ago, and the Global Fund, and life expectancy went up. HIV was the biggest killer of South Africans for 20 years, and suddenly it went down to number 7 in the space of just a few years. So we really made huge advances in terms of HIV. I'll talk about that in just a moment. So what did HIV do across the world? Well, it killed tens of millions of people. As I said, it was the #1 killer for many years in South Africa. And as I said, in many cities in rich countries, it was a major killer. And it continues to be a major killer in places, and is coming back in many places with the collapse of the PEPFAR program. So it still is a big deal. People often pit diseases against each other for reasons I never quite understand. Say, malaria kills more people than HIV. Well, it depends where you are. Some places in the world, malaria isn't a problem, and HIV is, and you can do something about both of those diseases, so get on with it. It's also fueled a massive tuberculosis epidemic, and with it, the multi-drug resistant tuberculosis epidemic. And certainly in South Africa, our TB epidemic is been dreadful. And with controlling HIV, we saw TB numbers coming down as well. And one of the things that was becoming a dramatic problem and drove many governments to act was it doesn't kill old people, and it doesn't kill very, very young children. It kills them indirectly, but it kills economically active people. So people get, often die in their 20s and 30s, and it doesn't kill them quickly in most cases. It kills them over 2 or 3 years, and this creates a massive burden on healthcare facilities. So there were secondary reasons for governments to act, that they couldn't ignore people doing this. Now, politicians don't like the people in many rich countries. The people that are often excluded from political debates and things, the people that politicians find difficult to talk about, gay people and people who use drugs, and particularly you're seeing this pushback happening at the moment. I'll talk about it in a moment. And it becomes uncomfortable for politicians to have to mention them. Ronald Reagan famously took a decade to talk about gay people in America, who were at the time the group of people most affected by HIV, and certainly my country and many African countries, it still is a difficult area for politicians to engage on. But they just had to deal with this. And one of the paradoxes of PEPFAR, an American program, was that they were one of the biggest funders of these key populations, that politicians don't like talking about. So in South Africa, for instance, there were, in a country of 60 million people, we now have about 8 million people with HIV, and it's probably closer to 6 million people on antiretrovirals, and many of them we've got a small number of people on subsequent lines of therapy. I'm not going to bore you too much about it. One of the biggest things that's happened in South Africa is we've gone down from about 70,000 children getting HIV every year to about 2,000. So pediatric HIV in South Africa is quite rare, compared. In fact, Nigeria, which is a much bigger country, but with much less HIV, actually has far more children with HIV than we do, even though our HIV adult population is much bigger. And as I said, it used to be our #1 killer, and it's dropped right down, and our life expectancy is leapt up because of treating it so effectively. And I'll talk about our new infection rates in just a moment, and come back to the incidence rate. And this talks about, shows you these peaks of death rates and how it's come down with the rollout of antiretrovirals. And as you can tell, COVID put a bit of a bump in our death rates, as it did in all countries. COVID is often under-recognized as to how devastating it was across the world in terms of death rates. In fact, in South Africa, COVID was the #1 killer during 2022. So it swept through. There's this narrative that Africa was really good at dealing with COVID, and it's absolute nonsense. It devastated the region in just the same way it devastated many countries. What's really interesting about HIV is how differentially it affects different places, and how still to this day it hits different communities in such different ways. And if you go down there, you can see in Southern Africa how still young women are affected. It still hits sex workers and it still hits gay men, but young women are still so heavily affected in Southern Africa. And if you go up towards Russia and Eastern Europe, you can see people who inject drugs are just hammered. It so differentially affects different groups. And if you go down towards Brazil, you'll see it's men who have sex with men. You go up towards the USA and Canada, you'll see again, it's men who have sex with men. You go out towards Asia, and you can see sex workers and transgender population. It's remarkable how different communities get hit by HIV, and how you have to have such different strategies for these different communities. And if you go down there, you can see how the epidemiologists piece out these different groups, how they look at prisoners, disabled populations, how each one of these carry their own special vulnerabilities, and how difficult it is for public health programs, which are often very shotgunny when they come to trying to deal with these. So it's all very well for in a place like Southern Africa, like you imagine, to go and find young women. A 20-year-old woman, she's out of school, she's unemployed. Trying to focus programs to go and find her is actually incredibly difficult. Once somebody's left school and they're out of employment, trying to find them and to focus a prevention program is incredibly hard. And paradoxically, finding a key population like gay men is actually quite easy. You can find places where people congregate either socially or where they buy products which are specifically focused there. It's often, because I've run many of those programs or have run them, those are actually relatively easy to find to channel those verticalized programs. So these, each one parts of these places, when you're trying to do programs which are trying to find people to either focus prevention programs or treatment programs, is problem. Now, this is the part, for those of you who are not medical, I can turn you into an HIV expert in about 5 seconds flat. So this is the bit, and it's not because I'm trying to be patronizing, it's because HIV really is now really easy to understand. And this is from a paper by John Mellors, who's one of these HIV venerables from Philadelphia, who has come up with this model, and we use this to train medical students. That's what we use to train specialists. It's what we use to explain to patients. It's really how you understand HIV. And the way you explain to people is, when people get HIV, they essentially, the way to understand is you're a patient who has a certain level of track, you're a train, and you're moving down this track. And the amount of track you have is your CD4 count, which is a group of immunologically active cells. We measure this every single day, and it costs a certain amount of money. It's about, in South Africa, it costs about $15 to do. It's a very easy test to do, and it's a very accurate measure of your immune system. And as you if you don't treat your HIV, this number goes down. Normal CD4 count is roughly anything between 500 and 1,000 cells, and it goes down and down and down. And the further down it goes, the more likely you are to get sick, and you head towards a disaster. On average, to get to a disaster takes about 8 to 10 years. And so it's a nice round number for us to remember. So we normally will say to somebody, from the point of infection to the point of getting sick takes 8 to 10 years. But some people have a great immune system and it takes them 20 to 30 years. Some people are born lucky or for some reason, they just don't move at all. Their train doesn't move at all. And for some people, they're born unlucky and their train moves in a year or two. So some people's trains just move for reasons that we think are genetic, or sometimes they just they eat badly, and for all sorts of lifestyle reasons, their train just might move faster. The speed at which they move is how high the virus is in their blood. So if we measure the bloodstream virus and it's very, very high, their train tends to move much faster. So those two metrics, the CD4 count and the viral load, allows us to predict how quickly that train is moving, how quickly that person with HIV is moving on that track. In the old days, these metrics were very important because we used to say, we're going to give you these ARVs, which are quite toxic. So we don't want to give it to you too early because we want to mitigate the toxicity. But as the drugs got safer and safer, we actually just gave it to them on the same day that we actually diagnosed HIV. And in fact, I was part of a whole lot of studies that showed that giving drugs on the same day, we used to think, oh dear, we have to really counsel people really carefully. But actually, because the drugs are so safe and people really want to take control of their health, giving them the drugs on the same day proved to be the safest thing we could actually do. It really drew people into the system and held them in the system in a way that we were quite remarkable. And in fact, across the world now, the standard of care is the day that you get your diagnosis, in the vast majority of cases, we will start you on your treatment while we're counseling people about the side effects and the importance of taking your treatment. And we now know that you need the antiretrovirals irrespective of the level of immunity. You get so many benefits and you feel so much better when you start the treatment. Often people don't realize how much energy they've lost due to the infection. So this, what we call this when to start to bed, which CD4 count, we used to say you start at 200 and then we drew it back to 350 and then we went back to 500. And then about 2010, we decided to do away with those thresholds altogether based on a whole range of studies which demonstrated that actually you got benefits irrespective of which CD4 count threshold you built. And that was based on the fact that the drugs just became so safe. The other good thing is, as I said to you, TB rates have been demonstrated to be coming down, and the drugs for TB have got better and better. So drug-resistant TB used to be almost a death sentence, and for a whole lot of HIV researchers went across to TB and have completely revolutionized tuberculosis treatment. And the good news is, even if you have extremely resistant TB, the drugs have got safer and safer and more effective, and people with tuberculosis and TB-resistant tuberculosis have got a really good fighting chance of actually making it through the TB treatment. One of the things that is happening is, as I said to you, young women are getting HIV still and are still extremely vulnerable to HIV. And when you go into Southern Africa and you ask the average person on the streets and you ask the average healthcare worker and you ask the average politician, they will go on and on about why this is. And I sometimes despair when I talk to people in the prevention field, and I despair when I talk to my fellow people, because there is so much morality and there's so much moralizing and there's so much conventional wisdom out there. And I bet you if I go to each one of you, you'll have 20 different opinions. But there is data to go on about this. And when you talk to our politicians, they will tell you that there's the entire reason these young women are so exquisitely at risk is they will tell you it's gender violence, they will tell you it's sugar daddies, they will tell you it's all about poverty, it's all about STDs, sexually transmitted infections. They will tell you it's all about 150 different things. And it does not explain to you why a young woman in Durban is 1,000 times more vulnerable than a young woman in Delhi or a young woman in New York. There is exquisite amounts of poverty in a place like Pakistan or in a place like multiple places in South America. There are incredibly high rates of gender violence in those places. There are phenomenal levels of gender disparities and things, and it does not explain, it's not the only explanation. There are sugar daddies galore all over the place. And there's actually really good data from KwaZulu-Natal to show that actually gender disparities in age in the relationships are actually not much higher. In fact, they're actually lower than in many places in the world. So these kind of conventional wisdom explanations for why young women are so vulnerable in this part of the world don't explain this vulnerability well. There are other explanations around circumcision rates, around forms of sexual partnering, none of which fully explain, to my mind, certainly why there is this vulnerability. There's no debate that there is vulnerability. It just doesn't explain the level of vulnerability. And unfortunately, by these kind of moralizing, and sometimes it's not terribly helpful in terms of allowing us to understand what the intervention is. So South Africa's politicians love paying for these big billboards saying, beware of sugar daddies. And there was a very good study done in KwaZulu-Natal, which actually showed that sugar daddies were highly protective against HIV. And in fact, there was some really good qualitative social science work showing why this might be. And when I approached one of the politicians who paid for these billboards and said, well, maybe you should change the billboards and put up and say, get yourself a sugar daddy because it's highly protective against HIV, that would make more sense. And the politician got incredibly upset and said, this is nonsense, you can't be talking like that. And the problem with it is it doesn't address the fundamental problem, which is a lot of what I suspect is layer upon vulnerability for these young women in terms of economic activity and a whole range of stuff. And one of the studies that was actually done in South Africa was improving the financial gains amongst young women in one of the studies in the Eastern Cape. And actually their vulnerability to HIV went up. So again, these unintended consequences around not fully understanding what you're doing with these things needs to be understood in the context of a really complex ecosystem in which South Africa exists. And I'd love to hear some of your explanations around this. In fact, these studies, which demonstrated how this transmission events happen, demonstrated that what was happening in these transmission cycles in this one community that was quite well studied in KwaZulu-Natal showed that young women were infecting young men at exactly the same age group as them. And then these young men were infecting young women a couple of years, like 6 or 7 years younger than them, which is not really what I would imagine to be a sugar daddy relationship. It would be more sort of often the conventional relationships that you'd see in most societies. And then this was the cycle that was being described, but actually was very located in the kind of age group below the age of 32. And in fact, past that age, there were very few HIV transmissions described in this particular group. So very, very focused, the cycle of transmission in this very tightly controlled group, as I said, below the age of 32. So it was a very important piece of research because it showed where you needed to focus your prevention control. What was interesting is that HIV incidence rates are actually coming down, and not just in South Africa, where there was actually a fairly dramatic decline between 2012 and 2017. It's actually been shown to continue in the last 10 years since then. And it's been shown to occur in Botswana, in Zimbabwe, and all the Southern African countries around there, and particularly amongst women. The incidence drop amongst men has been much lower, but has been fairly dramatic over the last, pretty much the last 15 to 20 years. So it does seem like prevention is happening, and in a manner that I actually didn't think was possible. It's, as I said, similar in all the countries around South Africa. What's interesting about Botswana is that they've been rolling out one of the most successful countries in rolling out the antiretroviral program, and actually didn't show any drop in incidence while they were showing very high rates of antiretroviral reduction. But now, finally, it's been showing a fairly dramatic drop in incidence. And across the world, in all the big cities where they've been rolling out antiretrovirals, they've been showing dramatic drops in HIV. And a lot of this has actually been used with pre-exposure prophylaxis, drugs where you give it to high-risk groups. Think about it's very similar to the way you conceptualize malaria prophylaxis. You're going to take drugs to stop yourself from contracting something that you don't want. You give drugs to people who are high risk. In many of these places, you give it to people like gay men, or to sex workers, or to people who have internalized the fact that they're high risk, going into high risk situations. Certainly in Southern Africa, we tend to focus on sex workers, on intravenous drug users, on young women. And this is a very uncomfortable slide for many people, but it's very uncomfortable for public health people. But we have essentially made sex safe. with the use of antiretrovirals, something we didn't know in the past. So if you treat people with HIV and you bring their viral load down to 0, they do not transmit the virus. And there's very few places in medicine that we can make such a categorical statement that they do not transmit the virus. And this has become a popular statement across public health in HIV land, is that what we say is undetectable equals untransmissible. Is that if you bring the virus down, you can actually throw the condoms away for the purposes of HIV. The other reasons to use condoms, which are around STDs and pregnancy and other things. But certainly for the purposes of HIV, in discordant couples where one person is positive and one's negative, if the positive person is taking HIV treatment, there's no reason actually to continue to use other forms of transmission protection. And certainly in the case of pre-exposure prophylaxis and post-exposure prophylaxis, so for if you're going to have an unsafe event, or in the case of post-exposure prophylaxis, or you prick yourself with a needle, we know that the drugs are remarkably effective. When I was training as a medical doctor, post-exposure prophylaxis, we used to get taught that it was 80% protective. It's probably far closer to 99% protective. And we now have large amounts of data coming in around pre-exposure prophylaxis studies, which are driving those numbers up towards 99% with a whole range of new drugs, injectable drugs that we're using, which you've probably seen in the media in the last 2 or 3 years that are coming through. There's a new oral drug that's being developed by one of the drug companies, which we take once a month, which is we're hoping to have results in the next year or so, which probably also will be close to 100% effective. So let's get to treatment and these very amazing pictures of people, what we call the Lazarus effect of people being put on treatment. Some people still, about 20% of people still test very late, come in very ill. So we still see this. We see people coming in, these kind of skeletal looking people. We put them on treatment and still routinely we return them to good health. We prefer not to do that. And some people we still lose. But honestly, it is routine to take somebody with HIV and return them to good health. And I still have one of my favorite patients is somebody who is a very good ultramarathon, a big ultramarathon in South Africa called the Comrades Marathon, where you run from Pietermaritzburg to Durban, I think it's something like 90 kilometers. And one of my patients came in 1998, I think, in a coma, cryptococcal meningitis. And I've kind of lost touch with her in the last few years, but she's run 12 Comrades Marathons since she came in the coma. We patched her up, got her back on her feet, and she's running marathons. And, she's an everyday person in South Africa. So these kind of good news stories are actually routine. It really is remarkable. And the amazing things we did for kids as well. There are now children born in the US who are having whole grandparents. So it really is testament to what these drugs do. And these life expectancy tables, which come out all the time, seem to demonstrate there is a penalty for HIV if you leave your treatment too late. And that makes sense. Is a number of people will die because they started treatment too late. But it does seem to, if you start your treatment a couple of, if you with a relatively preserved immune system, your life expectancy becomes as close as damage to being normal. And modern side effects are becoming steadily less and less. And I actually get quite embarrassed as an HIV treater when I listen to the side effects of a disease like TB or diabetes or some of these other drugs classes. They really are, it's not to minimize having HIV and having to take drugs every day, but they really are minor when you look at them compared to so many other diseases. And every iteration of the drugs is a very old slide. Even in 2010, the drug side effects were relatively minor, but this is my entire world is studying drug side effects and things. And we've just unblinded a study today where I'm trying to think about what I can say, but essentially there wasn't a single patient who stopped, out of 600 patients who stopped the drugs because of side effects. And that's remarkable, that we managed to get that kind of result. And so drugs do cost a lot, and certainly a lot of what my work is around is to try and advocate for drugs and find nifty new ways to make them cheaper. And one of the drug studies that we're famous for is a drug study called Advance, who we looked at, and this was published in 2019, so 7 years ago, looking at two drugs, which are a drug regimen which is used now across Africa. Probably 90% of the world uses this regimen now for people living with HIV. And a variant of this is used in most of the rich countries. So a combination of a drug called TAF and FTC and Bictegravir. The commercial name is Biktarvy. Is almost used by almost everyone in North America and most of Europe. So this drug that we studied specifically, we were interested in, is a drug called dolutegravir. And the reason we wanted to look at it was it looked like it was going to be cheaper and more effective than the replacement drug we were looking at. And it's not offered in medicine that you get offered something that's better than the original and will be cheaper. And it's because the generic drug, that the generification of this drug was such that we could get it. And it outperformed the first drug beyond our wildest dreams in the last 6 years. And the HIV programs have done so well and have, across the world, patients have been done so much better on this drug, both from a metabolic perspective as well as from what we call persistence. People just tolerate the drug much better than its predecessor, which I'm not going to go into too much detail around. But for one thing, which I'll get to in a moment. And what we're seeing now is this evolution of drugs just being safer and safer and safer. And we've got down to one tablet a day. The new era, though, is what we call long-acting agents. These things are injectables. They're tablets that you can take once a week. There's a whole new era of them coming into the market in the next year or two, potentially once a month, oral tablets. But these injectables are the things also that people are looking at. Potentially injectables. The current ones are every 2 months, but they're sore and you have to take 2 different tablets, 2 different injections in 2 different places. There are all sorts of problems with how they're administered. They need cold chains. But they are the future, and they're probably the future for a whole range of different conditions, not just for HIV. But we're busy looking at all of these things at the moment and how we can use them. And certainly for pre-exposure prophylaxis, this is what's coming. And a lot of these injectable things are pretty much what's going to be the standard of care as soon as we can drive the price down. They're going to be making their way through. This is one of the injectables. This is one of my colleagues I work with, one really amazing woman called Lisa Sokela. I spent a day with her today looking at one of these studies. And then Sissy Kicho from Uganda, who I work with very closely as well. It's Lisa and her buddies, and Nick Payton, who is one of the venerables of HIV as well. These people are just amazing to work with. One of the things that happened to us, though, when we started putting out, this is what happens when you do these kind of studies and you're independent of the drug companies, is you come up with side effects that you didn't anticipate. Drug companies do studies on very rarefied patients. They take people who are very, very healthy, and they take, in the case of HIV, they tend to take middle-class white gay men who are very body conscious, and they test the drugs on them. And what we did is we took everyday patients from central Johannesburg on our study, and one of the side effects we saw, what we thought the side effects, but actually was just they were turning back in South Africa. We uncovered something that we'd never seen before, but this dramatic rise in weight on these new regimens. And we initially thought they were side effects of the drugs, and we're still unpacking exactly what this is. But what we actually think this is probably is a complicated intersection of modern life and food with the side effect of recovering from HIV. And we saw dramatic rises in weight. And the sad reality of this is that one of the big areas of HIV now is dealing with obesity. And one of the patients, while I was busy parading around and talking about these results, went from a BMI, those of you know this, went from a BMI of 27, which is slightly overweight, to a BMI of over 60. And this is despite all the counseling about diet and exercise and all the other nonsense that we promote. And certainly one of the biggest problems we have at the moment is within, certainly in South Africa, we have an obesity epidemic, is dealing with this explosion of people gaining rapid weight gain in the HIV clinic, and not having anything to offer them because these new generation of weight loss drugs are so expensive and so unavailable to the patients who really need them. And people with HIV are amongst the people who need them the most. So this is actually what we're dealing with at the moment. This is a generic thing that happened. We've been doing this with people without HIV. Is we've been eradicated with strong, but in fact, the things that kind of killed our great grandparents, which was like pneumonia and TB, have pretty much taken the back seat. Flu, and the things that are killing all of us now are hypertension and diabetes and cardiovascular stuff. And we kind of getting that under control, and cancer, and they're kind of trying to get that under control. And this is what's coming for people with HIV is we're getting the virus under control, but now we're dealing with this wave of other illnesses. We're seeing lots of hypertension, obviously the obesity stuff, and trying to deal with that at the same time. And this is what we're seeing now across the world is people with HIV are now getting older because of successful antiretrovirals. Antiretrovirals are getting safer and safer and doing less and less harm. And they're collecting all these old age diseases that are happening to people without HIV. And the challenge is trying to treat those as effectively as possible. And you can see this in HIV, in the epidemiology in South Africa. This probably holds for, certainly for Botswana and Namibia, it probably holds for Zimbabwe as well, is that you can see this line is communicable diseases, like all the infections are going down, and non-communicable diseases are going up. If you talk to South Africans, you'd swear they're all getting murdered, outside of their homes every single day. But you can actually see that accidents and injuries are actually a relatively unusual cause of death. But the things that actually is killing them is, the stuff that is hypertension, diabetes, obesity-related illnesses. And this is Paul Sachs, who's probably one of the most famous infectious diseases doctors, and talking about one of the studies that actually changed HIV, which is giving statins, anti-cholesterol drugs to people with HIV, which is one of the biggest steps forwards in HIV. So, antiretrovirals are actually not where the big stuff is happening. What's happening is actually changing the metabolic state. And he was why he said the major advances now, Paul Sachs is now my tennis partner, like somebody I go and play tennis against, is stepping away from infectious diseases now and is stepping into the realms of endocrinology and cardiology and other areas. So the breakthroughs are not going to be in infectious diseases, they're going to come elsewhere. And this study he was talking about is a very amazing study where they gave a statin called pitavastatin. The study was called Reprieve and started demonstrating these big differences in patients who had, sort of moderate risk cardiovascular disease, people with HIV, and just gave them a statin routinely and showed that they were less likely to die. It's not clear to me that this applies to Africans. We have a different way of expressing our cardiovascular disease in strange ways, but it's the first step forward, and it's the kind of study that we need to be starting to think about. So just starting to wrap up, HIV research really has transformed the whole range of diseases, transformed how we treat hepatitis B and hepatitis C. Certainly when I was training, it was absolutely remarkable. These diseases were almost untreatable. Now, hepatitis B is treatable, hepatitis C we routinely cure. It's starting to change oncology and understanding of how we use these oncology drugs. Certainly oncology is a much more complicated field than the hepatitis field. But some of the oncology areas are being transformed with different drugs that we use. It's just that really made us have honest conversations around sexuality. And certainly when I was training as a medical student, we had no lectures on sex. And, certainly when I came to, there's a rural bumpkin, came into the area of HIV, I had to very quickly learn about sex workers and gay men and, the whole range of the unmentionables, and starting up a trans clinic certainly forced me kicking and screaming into having to learn a whole range of things that I certainly did not know about. And it's been really good for me to have to engage with this. And issues around sex work, learning about how to deal with, the uncomfortable areas around migration and xenophobia in South Africa. These debates are important for countries to have to engage with, and certainly for medicine to have to deal with. And I think with all the pushback that we're seeing around right-wing governments taking over and trying to reverse a lot of the gains that we've made in medicine, these things are things we need to jealously deal with. Sadly, what happened in January last year and the destruction of the PEPFAR program has been devastating, particularly for my area of the world in terms of HIV programs. And don't believe the spin, it has been absolutely devastating. South Africa has been relatively spared that devastation. Even in South Africa, it's been devastating, and it's been far, far worse for many of the poorer countries. South Africa is a middle-income country, Zambia is a middle-income country, and we've still been hammered. And for the poorer countries, Mozambique, Lesotho, Swaziland, Zimbabwe, it's been difficult, absolutely devastating. And these papers which you can pull out, you can turn it, you can see the modeling that's been done. We still haven't got the data coming out yet on what the actual impact is, but it'll come. And it's going to come certainly this year. It's been a year. All the data systems that would have collected this data were dismantled by the same funders. So the dismantling of PEPFAR, the global fund is still, there's still money coming through there, but that's been cut dramatically. So we will see that the impact of that. And we can talk about that. I spoke about that extensively in my lecture, so I'm going to leave that. And it is important to understand how close we were. There was modeling being done for the rollout of this new drug in Capavir, which suggested that we would be able to break the back of the epidemic. And then we're going to have to do a huge amount of repair to get us back there. We've been set back probably at least a decade by the cuts that happened last year. And these new drugs can only reverse so far. And South Africa needs to be scared, because even though our government unfortunately thinks it can go it alone, we are going to be. I'm going to just go. I did cover this in the last lecture. So, but because of the collapse of our key population programs, a lot of our testing programs are going to be reversed. We probably are going to be pushed back at least a decade in terms of because our TB screening program is largely dependent on PEPFAR. Our key population program and our testing program is largely going to go back there. This does mean that people are going to be coming forward to test when they're ill, which means that they tend to be hospitalized. There's more hospitalization. And as I said, the early warning systems across the region are gone. So the Department of Health has no way of knowing, has no systems in place to be able to tell this. And even though we do have studies in place to demonstrate the epidemiology, these things usually kind of happen every 2 or 3 years. There's also a massive impact across the region. Just in South Africa, with the loss of 24,000 jobs and loss of a huge amount of money that was being injected by the Americans. And also what's happening is that the impact on neighbors. So for instance, both the economic impact in terms of the money that was going in there, but also the health impact of the loss of the health systems that went in there. So to start clearing up, HIV, I think, has mobilized in the past unprecedented resources for health. And I think that's been remarkable, is that when I talk to people in the diabetes era and who work in TB, who work in hypertension, I say, you need to have more ambition. You need to be thinking about what is this burden of disease, and particularly people that work in diabetes and hypertension. I think the burden of disease in those areas is remarkable. Malaria is done in aging, what does gender violence, what in mental health, in racism, like what does it do to people's health? You need to ask the resources to do that. And HIV was decimating our societies, and people turned around from communities and said, we need the resources to tackle that. And they got the resources, and they actually turned things around. I think it's also made evidence more central to medicine. And, we knew what it cost to treat somebody with HIV. We knew what it cost to test somebody. We knew that taking somebody who was involved in sex work and preventing HIV transmission onwards there, this is what the cost was to the society. And we could actually model those things and say, this is why you should be doing these things. And I think those levels of evidence are missing for so many other areas. We don't know what it does in diabetes. We don't know what it does in schizophrenia or in lymphoma. And I think that, with HIV, we really were demanding evidence all the time for the resources that we were committing there. And it really is something that we need to be demanding more in health. As I said, I mentioned earlier, these uncomfortable discussions around sex and these unmentionable areas of medicine, it really pushed these things front and center into a very necessary area that we were able to have. There was acceleration of drug discovery and really important discussions around how we do this. And activists, particularly in the US, pushed very hard for accelerated drug discovery. At times they were criticized for being reckless, and at times maybe there was some truth to that. But I think by and large, it was a very good discussion. And there's lots of history about those discussions and people saying, we're dying and we need to have this. We need to have this. You can't have decades of slow drug discovery. We need this stuff to be accelerated. And you can do that in partnership with discussions with communities to do it in a way that is responsible. And I think it's focused attention on things like patents, on how healthcare spending is happening versus other spending. And I think certainly my country, spending on soccer stadia, on arms, and there's still not enough attention in places like Africa on there always seems money for guns, there always seems money for sports events and for protecting politicians, and not enough money is being spent on vaccines and clean water and some of the other things that really have an impact on health. And certainly, to my mind, not enough advocacy around those things at a local level. But just to end off on a slightly gloomier note, I do think the challenges are looming in 2026. I think these PEPFAR cuts are alarming. I think around the world, the assault on vaccines, on public health, within America, certainly the withdrawal of HIV programs, particularly of PrEP, but even of antiretrovirals, the withdrawal in certain parts of Europe of right-wing governments starting to pull back on funding of their health programs is very, very alarming. The way measles is suddenly making an appearance. We just need to be guarding these things and guarding them jealously. I certainly took a lot of this stuff for granted, and I think that we need to be thinking hard on how to win those battles again. It's going to take a lot of creativity and a lot of pushback and winning battles that we thought we'd won and we could take for granted, and that obviously isn't the case. But I think HIV has taught us a lot, and we can certainly use some of those lessons. But also some of the things we got wrong in HIV, I think we can still reflect upon and take forward. And I think I've spoken yet again too much for, so I think I'll just end there. Thanks so much.
All right.
That's why I talk too much.
All right. Thank you very much, Prof. Vender. This was a very enlightening presentation. I listened very attentively right from the beginning, looking at the origins of HIV and right through the interesting perspectives on the implications of the current setup we are now having, where there is reduced funding on the HIV programs. Yeah, so I understand that the scenario is likely to get back to where we were in the 90s and 2000s, where we were seeing high death rates and very serious cases of HIV before we had drugs that are now much more effective as a result of the HIV programs. So in the next few seconds, I just wanted you to explain maybe your observations and your own thinking on what is needed by countries, particularly South Africa and surrounding African countries. How should they respond, and how should we respond given that we have reduced funding?
So I think there are different responses for different countries, and I think that, for countries like Lesotho and Swaziland, who are completely dependent on donor funding, there's no other response than donors are going to have to step in and are going to have to relook at things. I do think there needs to be a radical rethink for some programs. I think that we've been very one-dimensional in the way we think about key population programs. I think that it's always been we do it one way, and we've always done it the same way for 25 years for key populations. And I think we can be much more creative there. I think there's certain ways we've delivered HIV conventional treatment programs which need to be rethought as well. I think there's certain ways of monitoring that can be rethought, that there can be more innovation, particularly in places like South Africa and Namibia. Some of the middle income countries really need to be much more creative and more radical. I also think that places like South Africa need to be challenged much more harshly. I do not understand why South Africa couldn't help Lesotho. Lesotho is so poor comparatively, it's completely landlocked. And the first response from South Africa was we're not getting, the Lesotho people mustn't come and get their treatment from us. And I do
All
not
right.
understand why.
Unfortunately, our time is gotten to the end. Thank you very much for this enlightening presentation. Thank you very much, the audience, for appearing, for listening through. We look forward to presentations from you, Prof. Venda, and also maybe presentations from other people in the audience who might have something to present on this topic. Thank you very much. Paul, are you still there?
Yes, absolutely. And lovely. If anyone wants to engage by email, I'm really available. And I'm sorry for talking so much.
Eltony, can I just jump in? I'm going to take the moderator's prerogative and say we have extra time. I'd actually like to hear about your experience in Zimbabwe. I think that would be valuable, and have a discussion about that as well.
Thank you very much. So I think I could summarize it as very similar. The developments in Zimbabwe soon after the program was paused, the support program for HIV was stopped by the funding by USAID last year. I think the public sector in Zimbabwe is sort of in disarray. They have not yet come up with a coordinated response. But I think I could say there is a slight hope in the sense that the government had introduced something known as the HIV tax, which is sort of a small tax that is put on everyone's payslip. And this tax is the one that they've been using to respond and try and come in where there are funding shortcomings. But obviously, it's not enough. I also am aware that there is a plan to introduce some insurance program that is going to cover the people who are living with HIV. I'm not too sure how this is going to work and whether it's going to be effective or not. I'm also looking at other responses in other Southern African countries. Pretty much it's on health insurance, how the governments are going to respond going forward. I think that's what I can say for now.
Well, thank you very much. And Eltony, you've given teleclasses before, and I hope people will look back and look at the lectures that you've given, because they have been quite remarkable. You were in Lesotho for many years and experienced that, and I think that really shaped the way you've been looking at healthcare ever since. But so thank you to you both. I look forward to the next teleclasses. You can see them on the screen there. Next week, the Healthcare Infection Society is presenting a special lecture for them on the built environment infection prevention initiative. And then you can see a few others there. And thanks as well to our patron sponsors, Diversity, Virox, and Gamma. And LT, if you can just stay around, I'll just say goodbye to the audience and we can have a chat afterward. To our audience and to our speakers, thank you very much. This is time very well spent.